No? Nurses? Physicians. Okay, great. All right. My disclosures. So what is celiac disease? We are talking about a lifelong autoimmune disease that starts in the small intestine and is triggered by the exposure to gluten. What is gluten? It's the alcohol-soluble protein fraction in wheat, rye, and barley. And it can turn a beautiful elongated villi here to flattened or completely villous atrophied villi on the right. It is prominent, it's only possible in genetically susceptible individuals. That means that you have to either have the HLA-DQ2 or DQ8 haplotype gene, or both of them. So it's a lot easier to talk about where celiac disease is not found in the world. It's very, very low and unreliable data for sub-Saharan Africa and Asian Pacific region. Otherwise, in the world, it's about 1 to 2% of the population. And that is a large figure. So it is common to see celiac disease at any age, from early infancy, once gluten has been exposed, all the way into the elderly years. And the average diagnosis is about 40. So I was 24 when I was diagnosed, and we have people from all different ages coming into our clinic at Beth Israel. Oftentimes, and this is what's so upsetting, they've struggled for 7 to 11 years with undiagnosed symptoms before they actually get a diagnosis. And stunningly, of the approximately 3 million Americans who are walking around right now with celiac disease, only 17% of them are diagnosed. That's where you come in. So I just have to talk about the new kid on the block. You've heard of non-gluten sensitivity, non-celiac gluten sensitivity. This is confusing. There's no genes yet associated with this condition, but we're seeing this more and more in clinic. Half of my practice are people with gluten sensitivity. The only way that you can currently diagnose this is by ruling out the wheat allergy and celiac disease to come up with a diagnosis of gluten sensitivity. Interestingly, patients with gluten sensitivity have more significant symptoms, we find, than those actually with celiac in a large number of cases. So we really want to figure out what this is and what can be done about it. Now, it used to be that celiac disease would only be diagnosed if you had steatorrhea, you had lost a tremendous amount of weight, profound fatigue, or if you're a child, perhaps failure to thrive. But nowadays, the face of celiac disease is much, much different. Perhaps you are irritable, perhaps you have a little bit of fatigue, and you're constipated. And how many people, right, does that possibly rule in? Many, many people. So I was diagnosed, again, 25 years ago with dermatitis herpetiformis. Does anyone know what that is? That's an itchy, blistering skin rash on your knees, your elbows, your extensor surfaces, sometimes bilateral and symmetrical. It is horrible. It feels like having chicken pox, being wrapped in wire and then rolled down a cliff. That's what it feels like. So that's how I was diagnosed. I have a dermatologist in the Palm Beach counties, Dr. Patrick McFolland, who diagnosed me 25 years ago, and I am forever grateful to him for making that diagnosis. It completely changed my life. But this is just one of the many ways that you can see it's now presenting. Look at these non-classic symptoms, including completely asymptomatic. One of the reasons celiac disease is being missed so often is because it is such a chameleon. And we don't have enough time to talk about associated conditions, but it is an autoimmune disease, so of course it's related to all its autoimmune sisters. And there are multiple complications for untreated celiac disease. One of them being infertility issues in men and women, and miscarriages, as well as fetal and neonatal complications, which should be listed here. So the standard way, the gold standard to diagnose celiac disease these days is still to check the total IgA and the IgA-TTG antibodies, and if they're elevated, to do a small intestinal endoscopy with biopsy. There are supportive criteria, certainly, which are listed here, but they are not diagnostic. So we are working very carefully on finding diagnostic techniques that do not involve the invasive biopsy, but they're not there quite yet. Most importantly, no one should be put on a gluten-free diet before a diagnosis is made. Now, Thank God for the gluten-free diet. It is the cornerstone of treatment. It reverses serology. It clears up histology. But it's not perfect, and it's very difficult to do. In fact, I just wanted to show you, you would have to break this regular piece of wheat bread into 7,030 pieces. One of those pieces would be the amount of contamination that would contaminate a gluten-free piece of bread. And this is why it is such a difficult diet to follow, and patients with celiac disease liken it to being on dialysis. So, in clinic I talk a lot about healthy diets. I'm very much for a Mediterranean-style diet, lots of plants, lots of omega-3s, any way to reverse or help this inflammatory condition to quiet down. And these are just 5 of the gluten-free grains or pseudo-grains that I talk about a lot. So there's a tremendous amount of healthy, vital foods available on the gluten-free diet, but there are a lot of issues as well. These are the impacts on a person with celiac disease. We're going to talk about a few of them. It is 240% more expensive buy gluten-free foods than regular containing foods. A loaf of bread is usually about $6.50. When I buy a loaf of bread, I stick it in the freezer and I take it out slice by slice. And that's how I manage obesity. Negative factors affecting the quality of gluten-free products, many. So in order to get the mouthfeel, the texture, the taste, and sometimes the smell of what we used to eat, a lot of the manufacturers are making these changes, increasing starches and fats, trans fats, calories, sugar, and decreasing key nutrients, fiber, and a low number of the products are enriched and fortified. If only it were truly as simple as when doctors say, please avoid these foods, these gluten-containing foods. But it is not. Because if you look at this, this is Pam before she went on a gluten-free diet. Please look here and imagine all of the different things that Pam has to look at now and research before she puts them into her mouth. 13 out of 20 of the selected items had to be researched by Pam. And this is something that she's going to do for every meal for the rest of her life. It is very, very possible, and this is not meant to be discouraging. This is meant to show the practitioners in the audience that we don't simply send our patients to the internet and say, start the gluten-free diet. We really do need to educate as best we can. So you might recognize a lot of these things as obvious places to find gluten. But you might see that I've put Play-Doh down here. Play-Doh has wheat in it. It's not a problem unless you eat it, but it's a problem if you do. Medications and supplements, and here, imitation bacon and imitation seafood. They both have wheat protein in them. Who would think of that when you're getting California sushi roll, right? That's what's in there. So not to belabor this, but it's just as important where we're looking for areas of cross-contamination. So if we look, does that family have a gluten-free zone in their kitchen to help avoid cross-contamination? Are people eating communion wafers or matzah that have wheat in them? There are gluten-free alternatives to all of these. Are you kissing your spouse who's just drank a beer? And we don't get involved in social issues with our patients as best we can, but we at least let them know that that's also an area of contamination. Are they checking the tiniest things like their gums and mints? You can see how much time and attention this really takes to do it well. And medications, as you know, do not have to be labeled gluten-free. They don't even have to say what the source of the starch is. So if you're a doctor or an RD, RN in the audience, excuse me, I don't know how to go back. You can, if your patient's gluten medication does have gluten, you can ask for a compounded medication, or you can change it if possible. But this is one of the areas where we see a lot of patients, TTGs remain elevated. It's because of the medication that no one has had a chance to think about. And if that wasn't enough, gluten-free grains like quinoa and amaranth and millet and all those wonderful pseudo-grains, they themselves can be contaminated with gluten in the field, when they're being sent to the processing, milling, and even in packaging. So this leads all of us to state even the gluten-free grains themselves have to be labeled gluten-free in order for a patient with celiac to eat them safely. So in clinic, we see quite a number of patients who aren't responding to the gluten-free diet. What could that be? Well, in some cases, it's fructose malabsorption, microscopic colitis, or bacterial overgrowth, SIBO. All of these, fortunately, have remedies and treatments for them, but interestingly, they can mimic the symptoms of celiac disease. So if you're in the audience now and you're thinking about a patient who has bloating and gas and distension and early satiety, maybe they have SIBO on top of their celiac. It's so common that I'm talking about it every single day in clinic. But let's not forget that the most likely reason for non-responsive celiac would be that there's still accidental or intentional exposure to gluten. Weight, as we've talked about today, is an incredible issue, not just for half of the population in Western countries, but also for the patients with celiac disease. So at diagnosis, if 40% of them are overweight, that's another reason why people aren't being diagnosed as quickly in this country, because you expect them to be, stick thin with diarrhea. And that's simply not the case anymore. Obviously, if you've been malabsorbing for X number of years of your life, and suddenly you're on a gluten-free diet, you're starting to absorb, everything is starting to repair and recover, the villi are restoring, you may not be able to eat the same amount of food as you did once before. That's just one of the issues for continued weight gain on the gluten-free diet. In the interest of time, I won't go into the labs, but I did want to show, these are the labs, this is the profile that we like to do on our patients in the clinic, certainly looking at vitamin D, B12, folate, iron, and ferritin. Zinc, used to think of this just as an issue with runaway diarrhea, but now it's very much, of course, your immune condition, your status. What is the status of your hair, skin, and nails? So many complaints about hair loss and skin issues and nails can recover and be repleted just with some zinc. And as needed, we will use these others, certainly fat-soluble vitamins if there is diarrhea, or night blindness, or etc. So I don't want to belabor this, but I will just point out these are the major deficiencies we see in the clinic. These are our treatment protocols for them. I'd just like to mention that even in sunshine states, even in here at Sunshine States, probably because of sunscreen, aging, what we do with it, and the fact that there's almost no D in the diet whatsoever, we're seeing profound low levels of vitamin D. So please, please check your patients. If you're a patient with celiac, a person with celiac, please check your own vitamin D levels. Some of this can be remedied in a multivitamin, like the iron, but generally there's not enough vitamin D in a multivitamin to carry you very far. And just the last panel, B12, as you know, B12 can be low secondary to bacterial overgrowth. So we'll see this pretty frequently, or at least low normal. Zinc, again, with a 67% max deficiency at diagnosis, is something that should not be missed anymore. And of course, everybody knows that calcium cannot be measured successfully by serum. We always do it with diet analysis and making sure they get adequate amounts. So these are just a few of the things that I wanted to make sure to present. And finally, I'll end with just a couple slides. I like to think of this as, the wheel of health. These are the basics, though. This is the very basics. Patients need to be eating gluten-free, taking their appropriate supplements, certainly a multivitamin for their age and their gender and their lab values, but also just reminders of fresh water and spacing meals. I can't tell you how much time I spend talking about these basics, and then go much beyond that with probiotics and digestive enzymes and anything else that they might need to heal their gut from the inside out. And then finally, just for providers and people in the audience who might have celiac, definitely make sure that you know what your annual TTG is. It should be checked once a year. This is the antibody for celiac. And monitor nutritional deficiencies. Don't leave them out of the mix. Talk about symptoms, take the appropriate supplements as necessary. If a repeat biopsy is needed to check on your status of your villi, then that's done. And bone scan. A bone density is recommended for people with celiac disease much earlier than age 50 for the regular population. That makes a lot of sense because in the first year on the gluten-free diet, people can recover so much bone health just by taking the needed calcium, D, the multivitamin, and being on the diet. So this is recommended earlier than it typically would, although the benefit is slightly uncertain. It's on here because we've seen such a great number of people with osteoporosis in a young age parameters. And finally, just wanted to leave you with some of the resources that I really like, the ones that I really respect. These are nationwide. This is our hospitals with a tremendous amount of nutrition medical information if you'd like it. These are various groups, organized groups in the United States. And down here, the newest one, National Society for the Study of Celiac Disease, North American study. If any physicians, RDs, or RNs in the audience are interested in celiac, you can join this foundation and be part of the cutting edge of getting the information out about this. And I'd just like to thank everyone very much for inviting me, letting me talk about this. I know that since there's 1 in 100 people with celiac disease, that there's at least one other person in this room who's on the diet like I am. So, thank you.